Abnormality means bladder uterine interface is react, irregular and hypervascular. Then next point is retroplacental myometrial thickness is less than 1 millimeter. This is seen in case of placenta percreta. And turbulent blood flow with color Doppler through lacunae. Extension of villi into myometrium, serosa and bladder. This picture shows the loss of normal hypoechoic retroplacental space. And this picture shows bladder and uterine bladder interface hypervascularity. And this is a TVS finding which shows the lacunae and subplacental vascular spaces. This slide showing here the normal retroplacental hypoechoic space is lost, and here bladder uterine and bladder interface is hypervascular, and here vascularity, the lacunae seen are very much vascular. This is the same findings in transvaginal ultrasound. We have to see here the lacunae, how they are filled with turbulent blood flow. Then what is the sensitivity and specificity of invasive placentation? We are here taking consideration into 4 points: placental lacunae, loss of hypoechoic space, abnormal uterine bladder interface, and color Doppler abnormality. Placental lacunae has a very high specificity, and loss of hypoechoic space and abnormal uterine bladder interface in case of anterior placenta previa, when it is irregular and hypervascular, it has a 99% specificity is there. Then color Doppler abnormality, high flow is seen inside the lacunae and in the bladder, uterine bladder interface. This picture is a transvaginal picture. This is called crossover sign. We have to, this is the uterus. We have to take a line from the fundus to internal os and external os. Then we have to locate gestational sac. Then after that, we have to measure the overlying myometrium anterior to the gestational sac. It should be less than 8 millimeter. This is called crossover sign, and it is applicable only cases below 8 weeks of gestation, because after 10 weeks, usually this gestational sac grows upwards and it is difficult to diagnose whether it was low-lying or not. This is called crossover sign and is used in pregnancy below 8 weeks. Then summarizing about placenta accreta spectrum. We have to first localize the placenta, then measure the distance from lower margin of the placenta to internal cervical os. Then upon 2D grayscale, what we have to see? We have to see loss of clear zone is there or not, abnormal placental lacunae present or not, bladder wall interruption, myometrial thinning, then placental bulge and focal exophytic mass, sometimes seen in case of placenta percreta, where placenta bulges through the serosa. Then when we apply color, all these things we have to see, like an uterovesical hypervascularity in case of anterior placenta previa, then subplacental hypervascularity. Bridging vessels. Bridging vessels means the vessel crosses from myometrium to placenta perpendicularly. Subplacental hypervascularity means all these vessels run parallel to the myometrium, but bridging vessels, this is perpendicular, the vessels run perpendicularly from myometrium to the placenta. Then placental lacunae feeder vessels and 3D intraplacental hypervascularity. Then coming to placental abruption. Theoretically, it is bleeding behind or within the placenta associated with painful uterine contractions. Incidence is 0.5 to 1%. Ultrasound, in ultrasound, we see hypoechoic subchorionic thickening. Ultrasound detection is 50%. Why? Because we see this hypoechoic subchorionic thickening only in case of concealed variety of placental abruption. So we have to remember that normal ultrasound does not rule out an abruption. So placental separation with active bleeding lead to maternal paternal emergency, which immediate triage is required. This slide shows placental abruption. This is the placenta, and here a crescentic hypoechoic mass-like structure seen, and we have to remember that it is avascular because it is the blood behind the placenta.
That means if you put color, you will not be able to see any flow.
No, because it is not supplied by vessels. Only some bleeding has occurred retroplacentally. So mass is seen. It is interspersed between placenta and myometrium, and it is avascular. Then coming to twins, how to determine amniocity and chorionicity. We have to remember that to determine chorionicity, first trimester ultrasound is always the best, because after on later gestation, amniotic membrane, separating amniotic membrane we can see, but chorionicity becomes very difficult. So in early trimester, in this diamniotic dichorionic pregnancy, this is the separating membrane, and here chorion is interspersed within the two amniotic membrane, leading to giving rise to lambda sign. This is called lambda sign. So in first trimester, we have to see this point and we have to assign the chorionicity to the twin pregnancy. This is lambda sign. Then diamniotic monochorionic pregnancies, interspersed intervening membrane is seen, but intervening membrane is perpendicular to the placenta, which is called T sign. That is diamniotic monochorionic pregnancy. In monoamniotic monochorionic pregnancy, no intervening membrane is seen, and the two cords are seen inserted into the placenta. That is monoamniotic monochorionic pregnancy. Most important part is we have to assign chorionicity in first trimester itself. Coming to second part of my topic, amniotic fluid.
Madam, can you just interruption? Can you come back to the previous slide? Can you come back to the chorionicity slide? See, right, I don't know whether you will be able to see the pointer. Here in the topmost right, you are seeing the lambda sign. Now, it is important that we see chorionic tissue in between the two membranes. In the lower part of this image, there is something looking like lambda, but actually there is no chorionic tissue. So sometimes don't confuse with this. This is called black lambda sign. This is known as black lambda sign. This is not a true lambda sign because there is no chorionic tissue here. So it is a diamniotic monochorionic. Thank you. Go ahead.
Then second part of my lecture is amniotic fluid, how to evaluate it, what is polyhydramnios, what is oligohydramnios, and how we are going to evaluate amniotic fluid in twins. Theoretically, amniotic fluid volume in first trimester production is poorly understood. It is multiple sources, maternal from the placenta and membranes. And second and third trimester, fetal urine is the major contributor from 16 weeks onwards, include and lungs also. So assessment of amniotic fluid volume always gives about the assessment of fetal well-being. So we have to remember when there is oligohydramnios or something like that, we have to see the fetal urinary system. Then abnormal amniotic fluid volume. When it is increased polyhydramnios, decreased oligohydramnios, no fluid, that is anhydramnios. Then how we are going to measure amniotic fluid? It was previously taught we have to divide abdomen into 4 quadrants, and we should place the transducer sagittally perpendicular to the floor without applying much pressure. Minimal pressure should be applied. So points should be remembered. We have to keep the transducer sagittally perpendicular to the floor with application of minimal pressure. So angulating the transducer is not a correct procedure to measure amniotic fluid volume. Technique is always minimize the pressure. Then amniotic fluid volume, also another factor we have to remember that while measuring there should be no cord or no fetal parts in these pockets. How we can avoid that? By applying color, we can avoid whether there is a umbilical cord intervening these pockets or not. So we have to take a measurement of 4 different quadrants and add this. And it is measured after 16 weeks. Normal it is 5 to 24. Oligohydramnios is less than 5 and polyhydramnios is more than 24. Another method of measuring is deepest vertical pocket. The measurement of deepest vertical pocket in any quadrant of the uterus. Its normal is 2 to 8 centimeter. Oligohydramnios is less than 2 centimeter. And when it is more than 8 centimeter, it is polyhydramnios. And DBP in diagnosing oligohydramnios, it is same outcome as compared to AFI. So any one we can take. Repeating again this, polyhydramnios, DBP should be more than 8 centimeter, AFI should be more than 24 centimeter. Oligohydramnios, DBP is less than 2 centimeter, AFI is less than 5 centimeter. This slide shows here 4 quadrants are taken and each measurement taken and then add all these 4. That gives to AFI. Here they have added color so that where umbilical cord is intervening these pockets or not, we can see. Then coming to causes of polyhydramnios. Mostly it is idiopathic. Maternal diabetes is one of the leading cause. And in fetal causes, anemia, structural malformation, chromosomal abnormalities, infections, genetic syndromes, and complicated twins. The polyhydramnios leads to increased incidence of preterm labor and delivery, thereby increasing perinatal mortality rate. Oligohydramnios, PROM is the most common cause. Fetal condition, that is bladder obstruction or renal failure. So when we are seeing any case of oligohydramnios, we have to see whether there is a fetal KUB, kidney urinary bladder, we have to focus. Then placental insufficiency that leads to IUGR and oligohydramnios. Maternal disorders by affecting the placenta also oligohydramnios like hypertension, renal disease, in multiple pregnancy, twin to twin transfusion syndrome, and selective fetal growth restriction. All these two leads to one sac is polyhydramnios and the other sac is oligohydramnios. Then others, maternal medication ingestion and substance abuse and different infections. And oligohydramnios leads to fetal deformities, fetal heart rate abnormalities, and meconium stent fluid. So what we have to keep in mind, while measuring AFI, transducer should be held sagittally and perpendicular to the floor. In case of suspected polyhydramnios, all 4 vertical fluid pockets we have to measure. In case of oligohydramnios, we have to measure single deepest vertical pocket. Be it oligo or polyhydramnios, we have to look for any maternal disease or fetal structural abnormalities. And in all these cases, follow-up ultrasound is always required. Then amniotic fluid assessment in twins. DBP here is used, not AFI. Like DBP, AFI, amniotic fluid volume is stable in normal monochorionic and dichorionic twins between 17 to 37 weeks. And definitions for oligohydramnios, polyhydramnios for twins is same as in singleton. And dichorionic etiologies also same as those of singletons. Only in monochorionic, these two conditions, twin to twin transfusion syndrome, where one sac we find oligohydramnios, other sac we find polyhydramnios, and selective fetal growth restriction. In one sac we find oligohydramnios and other sac may be normal amniotic fluid volume. Here this slide shows amniotic fluid volume assessment in twins. Here only 2 deepest vertical pockets seen in 2 of the gestational sacs. Then monochorionic diamniotic pregnancy. This slide here it is oligohydramnios and other sac showing polyhydramnios. So diagnosis is twin to twin transfusion syndrome. Then what are the key points we have to remember? The placental age is less than 2 centimeters from the internal loss should be considered as an at-risk pregnancy. So we have to follow up the case with repeated ultrasound scans at intervals. Then vaginal bleeding with ultrasound evidence of placental separation is an obstetric emergency, that is placental abruption. And placenta accreta should be excluded in all cases of low anterior placenta with previous cesarean section. Ultrasound here helps us to make preparation to face the obstetrics emergency during delivery, whether we are doing normal delivery or cesarean section. Then amniotic fluid volume, normal AFI is 5 to 24 centimeter. DBP is 2 to 8 centimeter, and DBP is used for assessment of amniotic fluid in twin pregnancy. And polyhydramnios is associated with increased risk of poor outcome due to preterm delivery. Thank you. That completes my lecture. Thanks for patient.
Madam, can you go to a previous slide? I will just tell one slide, one previous, where you are, yeah, this slide. See, this is an ideal way to measure deep vertical pool in twin pregnancies. Sometimes we don't get this particular view. So what we do is we turn the patient, you know, patient is lying supine, we turn the patient and see and follow this membrane. So once we follow this membrane, we will see this type of pocket. It is very, very ideal to get this type of view by moving the patient to different position. Then only we can get this particular view better. So this was just a technique we use, means to get this particular, the patient has to be turned in case we are not getting this view. Thank you.
Thank you, sir. Thanks all my colleagues for patient listening.
And I think the ebook which we have given to all the trainees, these steps are completely shown to them. And if you are able to access the videos, then also you can see the practically how it is being done in that video. And that ebook, please read ebook to look at this actually.
Okay, everybody has a link to the ebook and you have downloaded them.
There are many videos are linked. If you can click to a particular key, then I think videos are accessible. There are actually during download it is written actually. So
there's a question here. Pramodini, can you repeat diamniotic? What was Madhumita Mahanti's question? Can
Madam,
you
twin
repeat
pregnancy?
diamniotic dichorionicity in twins, please? Go to that slide and show.
ये स्ट्रक्चर तो अच्छी
Diamniotic, dichorionic, separating membranes are seen, and here we are seeing clearly some chorionic tissue is interspersed with between the two amniotic membranes, that is giving rise to lambda sign. This is
This means
diamniotic,
it is diamniotic.
dichorionic.
Dichorionic.
Dichorionic. Then
Diamniotic. Amniotic also membrane has to be.
because there are two amnions, because there are two amniotic sac and there are two placentas. So this lambda is an indication that two placentas are there, but they are touching each other, and in between the membranes, the one of the placenta or from the both the placenta, the chorionic tissue has gone in between the two membranes.
Therefore, it is quite thicker than in comparison to the T sign.
It is thicker, and also the downward, the black lambda has no chorionic tissue. This is just an infolding of the membrane. Just an infolding of the membrane. Ashok sir is there, he will clarify better. He is our guru. He has taught me a lot of things actually.
No, this is exactly what we refer to as the lambda sign. We know that as pregnancy progresses, the placentas grow in size. They're often not enough space for them inside the uterus, and they're close together. So then we don't know whether it's a single placenta or not. But if we see the lambda sign, that means the placenta has had an opportunity to grow inside that wedge-shaped structure. And that means that there has to be two amnions. Because if there was one amnion, it could never have grown into the sac. And therefore, it's straightforward, a very, very useful parameter for assessing that, yes, this indeed is the actual lambda sign, and it's a dichorionic pregnancy. So that answers it quite simply, exactly the way Dr. Hasmukh told us a few seconds ago. Yeah.
Hello, Dr. Dilip Kumar Patra, are you screen sharing? No, stop sharing. Dr. Patra, stop sharing your screen. Your screen is coming in. Okay, now any more questions? Dr. Khurana, you want a resume of the whole thing and any specific points you want our
Well, we have understood from this talk that we can stratify our pregnancies for the type of care that they will require based on the placenta. And we know that one of the primary functions of the FRU is really to stratify care. Can this patient be left to go home and will be reasonably safe at home? Should we give her some options and say no, try and find out some relatives nearby? Or is it something way beyond the reach of my unit, and I should suggest to them to report to a tertiary care center where the mother and the fetus would both be safe? So the stratification of twin care, we have already understood that the moment you have dichorionic pregnancies, we are comfortable and you can define them very early in early pregnancy. The dichorionic ones, we will follow up every 4 weeks. The monochorionic, we will follow up every 2 weeks for an ultrasound scan. When it comes to a low-lying placenta, we've learned the definition and we've learned how to measure from these slides that my placenta is so many millimeters away from the internal os. We have a rough idea that yes, before 28 weeks, if there is a catastrophe, there is pretty not much I can do about it to give the fetus intact survival, which means have a baby that is intellectually normal. Therefore, I will leave it alone until 28 weeks, be practical, and this is what they do in the NHS as well in the United Kingdom, and say, all right, maybe there's a difference of 26 and 28 between them and us, but at 28, we will reevaluate. If it continues to be low, I will warn her that, look, I need to follow this closely because I need to know whether you can deliver back at home under supervision or you have to be referred to a tertiary care center. So that becomes extremely important to then stratify this patient, definitely come back to me between 28 and 32 weeks to re-stratify her on where she should be delivering. When it comes to the placental invasion into the myometrium, that is an extremely dangerous situation, and I have to decide where to deliver because I will need a big team in case she bleeds. My first guide, as we have learned, is that the moment I see placenta previa and she has a previous cesarean section, I know that this placenta is not likely to go up. I will do my color Doppler evaluation at the same time and see, is she invasive already? Should we even allow her to go back to a remote area for the rest of her pregnancy? Because every mother is precious to you and to me. The second thing is that, okay, it might not be invasive today, but might become invasive towards the end of pregnancy, in which situation I must reevaluate her at 32 weeks and then again at 36, depending on what I see, and plan delivery at 36 weeks in the presence of a specialized team. So this stratification of the life-threatening situations becomes extremely important. And it is possible on the basis of a nice, well-done, easy to do ultrasound scan, because now you've received such a good practical lecture from Dr. Swain. The second part that has been highlighted, of course, is the evaluation of amniotic. And first, of course, there were some questions that Professor Sharma had to me for deciding the nomenclature. Nomenclature is quite simple. We still use the word oligohydramnios and oligoamnios interchangeably. And we still use the name polyamnios and polyhydramnios interchangeably. And both are absolutely good. The second thing is the interpretation. And we have learned that in oligoamnios, there could be abnormalities if it's not a leak. And therefore, I truly need to be careful and see how best to handle this pregnancy. The question that has been controversial over the years and has seen a change is that somewhere in the late 80s, we were trying to classify oligoamnios as mild, moderate, and severe because we believed at that time that it was a great indicator for prognosis. We've learned since then on patients that we've been seeing more and more frequently that maternal intake of fluid, ambient temperature of the environment, and therefore the amount of perspiration of the mother can reduce the amniotic fluid by up to 20% between morning and evening and morning to afternoon. A 20% change in amniotic fluid volume can change my amniotic fluid index from 9 centimeters to 7. And therefore, I was over assessing oligoamnios, and therefore I was overdoing my stratification. I was doing too many cesarean sections based on this, and it did not have a physiological correlation. We have therefore now shifted the concept to anything between 5 centimeters and less or 5 centimeters and more. So 5 centimeters and less is now where we are going towards a critical oligoamnios, and Beyond 5, we call it normal because we no longer think that non-critical needs any attention. For polyamnios also, we used to use previously 20 centimeters, 24 centimeters, and more than 24 centimeters. Now we feel that the prognosis is pretty much the same, and we only use more than 24 centimeters to define a polyamnios. So we now use 5 to 24 is completely normal. Have we changed anything in terms of the measurement of vertical pocket? You saw those beautiful slides and guidance for measuring the deepest vertical pocket. We have understood now that we might reduce the 2 centimeter pocket to a 1 centimeter pocket, but the guidelines don't say it as yet. Somewhere in the next year, the guidelines will change the 2 centimeter to a 1 centimeter so that we don't be in a rush. So that becomes extremely important. And the same thing for a polyamnios. 8 will remain 8 for the time being and will remain 8 forever. The third thing that we must understand is that there are certain concepts that have truly been thrown out of the window. One of them is assessing too much or laying too much importance on placental thickness. We know that a wide placenta will be a less thick placenta and a narrow placenta will be a more thick placenta. Therefore, we now have started moving back to our original method of a subjective evaluation of the placenta rather than an objective evaluation of the placenta. Objective evaluation and measurements are cumbersome, take very long to do, they are not reproducible, and not necessarily with a consistent bad clinical outcome. Therefore, we say, all right, we will just call it the placenta appears bulky or the placenta appears thick. We measure it only so that we can compare it over a period of time, and that is understandable. Also, we know that if there is polyamnios, the placenta appears thin. So again, the same thing, it is better to have a subjective evaluation. The question arises, if I have an objective evaluation of, say, amniotic fluid, and I get a reading of 5.1 centimeters or 7.1 centimeters, then what do I do? Do I call it oligoamnios? Do I say the LICA appears mildly reduced, appears moderately reduced? And how does that fit in with my overall clinical thinking for follow-up? My follow-up will never be based on the basis of an oligoamnios, unless it is less than 5. My follow-up will be based on the total picture. Have I excluded anomalies? Have I excluded a rupture of membranes? Have I excluded amnionitis? We all feel that amnionitis has no manifestations, but painful movements, tender uterus. My patient tells me it's hurting when I'm doing the ultrasound scan. And I find a very remarkable reduction in amniotic fluid over a short period of time with a normal Doppler. I'm thinking of amnionitis, and that helps. What will I do to corroborate this? I will do my total count. And in this day and age, I can do a C-reactive protein, and it will tell me about amnionitis. So we use it as a starting point, but we don't use it as a critical clinical decision-making point. Critical clinical decision-making in the placenta is used with color. So placental function is assessed with Doppler. Placental abnormalities are assessed with Doppler. Placental anechoic spaces are assessed with Doppler. Placental invasion is assessed with Doppler. Vasa previa is assessed with Doppler. And placenta previa with abnormal vessels is again assessed with Doppler. Do I assess the lower margin of the placenta in color or in black and white? I assess the lower margin in grayscale, but to make sure there is no peculiar velamentous insertion of the cord in vasa previa, I will switch on color. Does this mean that ideally speaking, I should have a color unit? Yes, this means that I should not possess any unit that does not have color Doppler today. Does that add to my price? No. A good color Doppler unit today is actually at the same price. We just have to look for the right technology. So whether I'm buying for government or for myself, I will make sure that I will use a color Doppler unit. So this in essence is how we use these things today as in 2022. There's no doubt that our knowledge is evolving and that we will go further. But as of today, this is where we stand on these two critical points, and we will cover them up, truly speaking, even with time. And that means that next year's talk may not have these values. Plus, towards the end of the talks, we would have taught you so much more about each of these aspects that we have discussed today that you will be better off. We did our previous talk for amniotic fluid index. Today, we've learned a little more about it. And tomorrow in one of our talks, we will teach you even more. And that is how we will go through all of this. And now back to any more questions, of course.
Thank you, sir, very, very much. Anybody else? You can unmute and ask. This is a privilege you are getting, rarest of privileges.
I have one question for Dr. Khurana. Of course, this is a for him because he lives in Delhi and he has a very specialized center. So, sir, what do you do in your center? Sometimes you diagnose ectita with only ultrasound, or you also confirm by MRI? Do you sometimes use MRI?
Please
I
repeat
use,
the question, Hasmukh sir. We
I
couldn't
use
hear.
a two-step process.
Yeah.
For my anterior invasive placentas, I'm reasonably sure with the help of color Doppler that it is invasive. For my posterior invasive placentas, I do an ultrasound, and if my ultrasound is conclusive for invasive placenta, or what we call morbidly adherent placenta, then I say, okay, it is invasive. If I have a posterior placental placenta previa, and I don't find evidence of invasion on my ultrasound, I will then refer for an MRI of the placenta, but to someone who is interested in looking at the placenta and to the fetus. So that is the strategy that I follow.
Thank you.
Hello. A very, very important message to all of you in the FRU. If you do find a placenta, invasive placenta in Creta, particularly for Creta, of course, will end up in a patient in shock. But if you find this kind of placenta, you have to refer this patient to a medical college where there is a multi-speciality, where blood is available plenty, and senior surgeons are there, so that these are the cases where, especially when the baby is valuable, the mother, they have to be, even in a medical college, it's very difficult to save one of the, because we have seen mortality even in SCV medical college of these kind of placentas when we have dealt with it, and they have been, we've lost quite one or two patients like that. So remember, if you do, when you're assessing the placenta, if you find this kind of placenta, especially between the bladder and the uterine wall, if you find that vascularity which Dr. Gupta, Dr. Pramodini Swai showed, remember, just don't sleep over it. You have to explain to the patient, counsel the patient properly and their relatives, and they must shift and they must get themselves admitted to a medical college so that they're in the high risk ward and things are ready so that crisis might occur at any moment. And these babies are normally taken up to the intact survival rate, maybe 32, 34 weeks, and then something is done at that time with a lot of blood and everything available. Urologist may be required to be roped in because it's so much close to the bladder. So all these things are there because we face this, you know, and it can happen. So I think all the specialists, please pay heed now that you've been given the technology of you're observing these placentas more closely. Please don't miss them. And if you find these placentas, you have to refer to counsel properly and refer them right from that duration of pregnancy, so that the patient will stay in the medical college till she is safe enough to for a cesarean section with multi-speciality, multidisciplinary help available in the medical college. and that would be MKCG or WIMSAR or SCB. The newer medical colleges do not have so multi-specialty, so it's a very important awareness that we must carry back home from today's lecture. Any more questions to Professor Khurana or Dr. Hasmukhlal or Dr.
I would like to say few things. As Ashok sir said, that guidelines will always keep changing because the subject is expanding, lot of research is going on, new data are coming. So I will just share what we used earlier, and Shyama madam, you are a witness to that because you are also my teacher. And we used to grade placenta, but then when Doppler came, we are doing the function of the placenta and not looking at grading system. So also is placenta previa. When initially we were there, we used to say complete, partial, and all that criteria, but the criteria changed to less than 2 cm, more than 2 cm, and whether it is coming the entire os as 2 cm. So that whole thing has vanished. The complete and partial, it has all gone with new criteria by SWOG, because lot of studies were being done at that time, that how much is the like 100%, or it was 83% of the placentas will become normal. I mean, because of the development of the lower uterine segment, not that the placenta migrates, but because the uterus elongates and then it moves away, the placenta moves away from the internal os. So this is one of the important thing we learned from Ashok sir in many webinars and conferences. And one more thing we have been knowing is, earlier we used to say transvaginal is not safe if a patient is bleeding, but nowadays with safety issue is there, that they say you can do transvaginal for even if the patient is bleeding in case of placenta previa, and especially when the placenta is posterior or the head is so close to the os that we are not able to see, then transvaginal is the best way to look for I mean, if we have to do transvaginal, and the safety is established that even the patient is bleeding, we can do a transvaginal scan. I think this is what we learned from Ashok sir, and I am sharing with you all.
Hello.
Huh, madam?
Sir, just I wanted to know, in case of like triplet pregnancy,
Yeah.
should we write lambda sign positive in for placental chorionicity?
I think Ashok sir, let him will answer this.
Any
Because-
triplet, I had a case of
Yeah.
triplet pregnancy. Should we write, it may be 3 placenta or it may be 2
Dichorionic,
placenta?
dichorionic, yeah. You could,
Yeah.
there are
So
3.
should we write there between 1 and 2 twins, it is lambda sign positive or T sign positive?
So when you write a report, it's nice in multifetal pregnancies to mention as much as possible. So for instance, I would mention that triplet pregnancy with 2 lambda signs apparent, indicating a trichorionic pregnancy. Or I would say pregnancy with 1 lambda sign and 1 T sign, indicating dichorionic triamniotic triplets. So that is how I would then go on to say this. Or similarly, I would go on to explain my explanation for 4, for instance. And therefore, we always mention, my first sentence is always what my conclusion was. For instance, trichorionic triamniotic triplets, or trichorionic, then I would make dichorionic triamniotic triplets. So that is how we go about it. Or sometimes I've even seen dichorionic diamniotic triplets. And then I will mention that the presenting sac shows this, and the aftercoming sac shows this. So the first paragraph should be a conclusion on top, indicating chorionicity and amnionicity, And the second section of that paragraph should have a detailed description of all that you have observed, so that the person who's examining this patient next time will have no communication gap. I know it takes a few minutes longer, but it is life-saving for the mother and for those fetuses.
Thank you, sir. Sir, another question. Have you ever seen there is an increase in this AFI after treatment with Fructodex or RG-Preg and all such things for oligohydramnios? Just I wanted to ask.
You know, strictly speaking, absolutely no. Strictly speaking, there is not even an improvement in Doppler. What does happen is that our mothers are overworked and malnourished. And the moment you introduce the concept of care, they start taking care of everything. So then everything becomes better, nutrition becomes better, and therefore everything improves. So we have never been able to assess these confounding factors or coexistent factors. So really speaking, there is no way that we end up. We used to use, 10% dextrose and things like that, saline dextrose, intermittent oxygen. We know that all of these things are definitely harmful to a fetus, definitely alter mother's glucose tolerance, and definitely result in all kinds of problems to the fetal brain if we use, for instance, that we used to use intermittent oxygen. So we should never use any of these things. They are not proven to be good. The only thing proven to be good is correction of maternal nutrition and appropriate intervention for when to deliver and where to deliver.
Thank you, sir.
Sir, one more, this is because most of the multifetal like triplets and quadruplets occur with AR assisted reproductive technology, and therefore isn't it better that it is at chorionicity is established at 9 to 10 weeks rather than doing that at 11 weeks or 12?
Absolutely true. You see, any time after 7+ weeks, all the good sacs that are going to be there will be there.
Right.
So at least if I see 2 gestational sacs, I will mention 2 gestational sacs. I may not be able to evaluate amnionicity at that time, but I will definitely do chorionicity as early as possible. And by 7 weeks, the number of sacs in ART would be well known. If, of course, it's a spontaneous conception, you never know, one growing a little slower, one growing a little bigger, but all ART pregnancies should have chorionicity established soon after 7 weeks. Amnionicity, we may not be able to see the amniotic portion, and therefore is to be done latest by 12 weeks. But in most of these, with a meticulous, systematic transvaginal scanning, at about 9 weeks plus, we are able to tell the amnions fairly clearly. In fact, when we map the fetus, it is much better to do it at about 9 to 10 weeks rather than later in pregnancy, because then you can say which one is superior, which one is inferior, which one is left, which one is right, and which one is in the middle, and so on for the multifetal ones.
Hello, any more questions? Shall we go to the poll? Post poll?
I think so, yes.
All what we learned is we have to keep the transducer longitudinal, and to look for the inferior margin of placenta, we go from upper quadrant to the lower side.
Fundus to,
yeah, from fundus to the internal os, so that we can ascertain its distance from the internal os. We have to look to the inferior margin of the placenta actually. And yeah, I think that's we already talked about all the issues, I think mostly.
Sambit, please,
Hello.
requesting
Hello.
all of you,
Madam,
please attempt the post poll questions without fail.
Madam
Okay.
Dr. Gitanjali, I have one
Gita-
question, madam.
Yes, you ask. Professor Khurana is there.
Madam, patient came at 32 weeks with AFI 6. After 2 weeks, patient came with IUD. What should have been done to this patient?
AFI6, what do you, how
At
did you
32 weeks, at 32
Yes,
weeks,
32
patient
weeks,
came with a
AFI6,
6.
then what did you counsel the patient and what did you do with the patient? Why did you
I-
allow her to go away? Did you do the umbilical cord flow? Did you do the uterine artery blood flow?
No, madam.
And did you do the biophysical scoring, the breathing movements, gross body movements, all those did you see? Fetal breathing movements did you see? And then as today, see,
Just now,
listen,
madam
as
asked this
Dr.
question.
Khurana has mentioned, did you look, you should, of course, now we know it, even I didn't, I wouldn't have looked for it. Like you have to see whether there's tenderness, whether did you do a CRP, did you do a total blood, TLC, and so all these things we now will do in future when such a patient comes. AFI6, although we are not perturbed about AFI6, we should ask the patient about her fetal movement. Daily fetal movement count is what you have all to do after 32 weeks. Daily fetal movement count has to be asked to every patient. In fact, we are in our mentoring visits, we will be introducing this daily fetal movement count chart should be
Tick count.
provided
Tick
throughout
count.
the state.
I have asked
And
for daily
because mother is the best monitor, no ultrasound can go as a better monitor than the mother herself. If she feels fetus is not moving, then you have to be absolutely careful and you have to take her in. You have to admit her and you have to see her more clearly and look for factors regarding the fetal movement. Then serially also, of course, for your case, I don't know. Serially, you should have measured fundus symphysis length also. If it is flattening out, then you have to be absolutely aware and that you are dealing with the fetal growth restriction or some other problem with the anything. Professor Khurana, your comments, please.
I would fully agree with you. If I find the amniotic fluid reduced, I would try to ascertain the cause and make sure that I'm not missing, for instance, a renal agenesis, that I'm not missing a bladder outflow obstruction that has resulted in renal failure and it is now oligoamnios. I would like to ask her for a history of rupture of membranes. I would then move on to assess for placental insufficiency and do a biometry and Doppler. And I would then also move on to assess whether there might be amnionitis. And then I would be comfortable to say that, yes, I've excluded all these causes, but let me be careful and ask her to come in for a follow-up 1 to 2 weeks down the line, depending on whether it's closer to like 6.1, I would get very anxious and say, okay, come back in about a week's time, let's assess again. And if it's like 6.9, I would say, okay, come back in 2 weeks' time and I will assess again. But the investigation for the cause must start in your mind the moment you see that on an ultrasound scan.
Thank you.
But sir, just now we learned that AFI 5 is below AFI 5 is
Yeah,
Yes.
but
AFI
that,
6 is not a much
Yes, my child. So what we're really trying to learn is what is critical for decision making for delivery versus what is critical for assessing on why it is happening. So for delivery decisions, an amniotic fluid of less than 5 may be contributory, but it is right at the bottom of the list as of today. For deciding, is there something wrong with this pregnancy? Why is the amniotic fluid on the lower side of average? That then means that I must look at the amniotic fluid more carefully. So it's a question of words and the clinical scenario. So 5 is my critical point for possible delivery. Whereas more than 5, I must look for other causes of the oligoamnios.
and
Thank you
also
so
the
much.
fact it has to be kept in mind that when we are measuring AFI, there should not be any cord or any fetal parts, and especially we have to put color to exclude the cord.
Yes.
So then only we can, our measurement will be accurate. Actually.
Thank you, sir.
Sir, in
What you are referring to is a stillbirth may have some different causes like cardiac problem could be there, or sometimes chromosomal abnormalities also are the causes of stillbirth. So these are there are a lot of issues. I think stillbirth will one of the topic we will try to cover up sometime. And I think that see, point is all in in our SFM webinars, lot of different topics. This is the basic fundamental. This is a basic talk we are learning. But when we have to learn something advanced, I think SFM is a better platform where a lot of such cases, and in fact the real life scenarios are discussed also. So day-to-day life we come across.
Sir, suppose
Hello.
the patient is having a history of from leaking and FI is reduced, but for how many hours we can wait for a decision that will interfere or not?
So
I think
this
it's a good
is,
question.
yes,
Yeah,
now
like
this is
when the rupture,
a whole
AFI
session by itself. Yes. And what we really have to do is to realize that the invasion by the vaginal microbes is very rapid. And technically speaking, therefore, the only time I really have between a preterm premature rupture of membranes that happens after 28 or 32 weeks is, do I have enough time to get lung maturity by giving steroids? And that you can assess by looking at the degree of oligoamnios after a preterm premature rupture of membranes. You will also try and see, is that because the counts are high or the C-reactive protein is very high, then you won't wait at all. Then even one dose of steroid and you might consider delivering. Or that she feels no fetal movements, and that is my trick to say that, okay, this mother has noticed a remarkable change in fetal behavior. I don't have time. So that is a much wider topic, and we will take it up in one of these things. But in general, the time that we wait after PPROM is, truly speaking, only the time that we need for our steroids to give us lung maturity.
Thank you, sir.
Sir, hello?
In diamnotic monochromatic, what should you advise the patient? How to assess the patient at which interval of time?
So when we have a monochorionic diamniotic twin pregnancy, there is a well-defined guideline from all the various societies of the world that tell us that from 12 weeks onwards, we will assess them every 2 weeks. So 12, 14, 16, 18, 20, 22, and so on, without compromise. That is in an ideal situation. We can't say that, look, it looks all right, come back after 4 weeks. There can be a catastrophe between 19 and 22 weeks. So do not compromise. If the patient doesn't come, that is fine. Tomorrow, you don't want to hear that, look, I work so hard with my patients, and yet I lost these fetuses. So therefore, we must follow the guidelines, which is monochorionic, diamniotic. I must do a surveillance every 2 weeks.
Sir, what should you look for in every visit?
We have a whole talk on that, actually. We have a wonderful session coming up, 3 sessions down the line, on surveillance for twin pregnancies. And we will give you the full protocol at that time. Yes.
Yes.
Hello.
I have a question to Professor Khurana.
Yes.
As we give steroids, between 28 to 32 weeks, you are taking a decision to terminate. Should we give Maxalt 2 grams 6 hours apart, which is now given in UK?
Yes.
And in some parts
So for imminent delivery,
neuroprotection?
1 shot of Maxalt is enough as a neuroprotective, and that's routine now to be given. If you think you're delivering faster, then with the first dose of the steroid, otherwise with the second dose. If you're using dexamethasone, then when you give your second dexamethasone, because that's a course of 4, then you give your neuroprotection.
So I think all the specialists, you know, when you are facing this kind of, you're getting it ready, getting your case ready for cesarean section deciding, you have to give steroids as well as magnesium sulfate for neuroprotection of the baby. That will reduce fetal morbidities and further improve our reduce our perinatal morbidities and mortalities. So
Yes.
remember Maxulf, I think we had discussed in our district mentoring visits. So now Professor Khurana reiterates that stand that Maxulf 2 grams, at least single dose intramuscular, will give neuroprotection to the baby. When
2
you are
grams,
giving
sir. 2 grams.
2 grams, yeah.
Madam, see, after Betnesol, second dose Betnesol, we have to wait for another 24 hours.
No,
we should give,
that is the time.
neurotransmitter.
That is the time Professor Khurana said in second dose of steroid you give intramuscular 2 grams of Maxulf. I hope everybody is
After-
noting this.
Thank you, madam.
Madam,
Yes.
AFI increases with the increasing gestational age. So so AFI should vary according to gestational age or not? Because if we think the AFI of 5 is normal at 30 weeks or not?
Yeah. So truly speaking, when we look at the graph of amniotic fluid index versus gestational age, we realize that the bottom level of the graph is pretty steady at about 5 centimeters. It is the upper level that can be variable, and you can have a physiological increase in the amount of amniotic fluid between 24 and 32 weeks. And therefore, for labeling polyamnios, we do not use a single cutoff like that. You can be a little borderline. But for determining oligoamnios, the lower part of the graph is pretty much at 5 centimeters throughout pregnancy, beyond 28 weeks of gestation. Before 28 weeks of gestation, it is wiser to use a deepest vertical pocket. And like we've heard today, the deepest vertical pocket should be free of any limb, and it should be free of any cord segment. And the ideal way to exclude a cord segment is to switch on Doppler and make sure that there is no cord lying inside that pocket.
Okay, sir. Thank you.
Thank you very much, Professor Khurana. Shall we
Thank you.
launch the post-poll questions?
I think so. I think we should go on to them. Yes.
Ambit, let's have the polls. I request all of you, Narottam, everybody, please attempt the post-poll questions after all these discussions and enlightenment, listening to the PowerPoints by Dr. Pramodini. Please attempt this for your own benefit.
Madam,
Today I have learned so many things from Professor Khurana and Dr. Hasmukh, Pramodini. So, Sambit, shall we launch the post-poll questions?
Madam, actually, in between, I got disconnected due to network issues. Now I am not the host. Professor Khurana is the host now, and he can make us the co-host so that we can launch the poll questions. We can regulate this meeting.
One moment, I will just make you
Sambit,
co-host.
find a participant and make post.
Thank you, sir.
I need to make Sambit co-host.
Sambit Jena.
One moment, I'm just making Sambit the co-host again. Make host. Yeah.
Sambit Jena is
done.
host now. Yeah, you can share.
Poll questions have been launched already. Thank you. Thank you, sir. Madam, poll questions are live now. Participants may attempt.
Yes. All questions are live. Please. Please, all of you attempt. Now much clarification must be there. Don't leave, please attempt the poll questions because each of the questions will be discussed after that.
And in fact, all the poll questions, when we are trying to give the correct answer, the lot of information will be shared also. So it is not only the you are attempting, but what
Because regarding the correct
to
answer,
clarify.
regarding the wrong answers also,
and I
a
have
lot
to
of
clarify
discussions
why
will
it is.
follow, which will help you. So please don't leave. Answer the poll questions. And we will not know who you are when you are answering. So your identity is not being disclosed. You are depriving yourself of another learnings opportunity if you are not answering the poll questions. It's just like election propaganda.
Post poll also, we are giving lot of other information which are relevant to the questions.
Don't click on the end poll.
Actually, Pramodini madam Tikke Aji Tankara, her father was sick. Today he is getting discharged, but she was very disturbed because of her father's illness actually. So in spite
But the
of that,
presentation was very clear and very.
in spite of that,
good.
she has
Very good
done
presentation.
it very well. Excellent. Yeah.
Thank you, sir.
बढ़िया ହେଲା प्रमोदिनी. बहुत clear ହେଲା.
Thank you, madam.
Yes.
I think that all the attendees should take a screenshot of this, and the correct answers are all applicable, and they are to be used in day-to-day practice. And one which is not right, we will of course tell you. So every MCQ, I think if there is a lot of information in MCQ itself. And this is one of the most interesting part which Syama madam wanted, that pre-poll and post-poll, just we have to ascertain and see how much of how much we are gaining in terms of knowledge and what is the impact of our labor. It takes an intensive time, and also that we are our trainers are preparing, and of course they are preparing the slides, adding something new and sharing information. So a lot of effort is being poured in this program, and therefore I think how much of impact it makes on all of your knowledge, it is assessed by this one. Yeah. So MCQ must be attempted. And please stay back so that a lot of information itself will be shared again. You can take a screenshot of this MCQs also and keep it with you.
Hope everybody is answering the poll questions.
In fact, Shyama madam role is she will go through each slide, all the MCQs, she will modify, and she will put something more important also there. So thanks to her, she has been doing a lot of work also.
No, because in the NTTC, we were taught question banking and evaluation. So the distractors and everything have to be as per some. There are certain rules which are, if they are broken, it's not fair for the person who is answering the questions.
Yeah, I think all the things which are there here in this MCQ were already there in the slides, and if you have heard the talk very well, I think you will hit all the 10 right.
And we have no right to ask any question which we are not presenting in our PowerPoint. It should be there, because there will be confusion after that.
Dr. Jalandhar Meher, you are listening to us? Jalandhar Meher?
हाँ सर नमस्कार अच्छी अच्छी
Namaskar, namaskar, namaskar. So I think you will see us on-site training at Bhavani Patna. Amar asibe jane Dr. Rama Manjari Nayak. She will come, and I have Bhavani Patna being so close, I will also be there. So maybe
sir.
we'll see you on site.
डेट केबे सर
Date टा final नहीं हवा, माने आमे कहमु आपन को.
ठीक अच्छे वो तो एबे रेडा खोल रे अछि एसडी मगर पठे दले नहीं अपन डेट दले मत निश्चय प्रेजेंट रहबे सर
Reda Hall, you are at Reda Hall. Okay. And your wife is there at Bhavani Patna, is it?
हां भाने पटना रे अछि
अच्छा, okay. Thank you. Thank you.
अपन डेट मते इंटीमेट करबे वो निश्चय प्रेजेंट रहबे सर
या आपण हमर ग्रुप रे जदी असन सब जानबे आमे देमु सब आपन को.
ठीक अछि सर
Jalandhar Meher is a old friend of mine, and of course I am speaking our regional language, so my friends don't get surprised.
The government notification दियाजिबो को trainer का पाखु जिबे dates पूरा दियाजिबो. We are working very hard on that, and we depend on Professor Khurana for that. And, with the UNICEF will be supporting that activity, and information will go throughout the state. All trainers will go. Those who are willing to go for on-site training, they will go to you. And since Hashmukh sir is close to you, he will definitely, we are taking that into account. The trainer who is closest in the district, which is comfortable or suitable for the trainer, will be given to the trainer. And it will be a joy for us also.
Okay, madam.
Hope you are enjoying the whole training.
आपण मुलर सुनुछन कि एबे जॉइन कले ई लेक्चर ता आई हैवंट सीन यू
नहीं मझिरे करतले दुई तीनटा मिस ही गला
अच्छा
Deepak,
बहुत बढ़िया
hello Deepak, you are not Deepak. Yes, Deepak is my PG. Deepak, where are you now?
Ma'am,
Deepak, where are you posted now?
Burla, madam. Now Burla, madam, doing senior resident.
You're doing your SR at Burla. Oh, good. Hope your postgraduates are also joining this training.
Madam,
Ask Ojoswini Madam, Mamata Soren, that the government has allowed all the postgraduates to attend this training. They must not they must not miss the golden opportunity of contacting Professor Khurana.
Again, ma'am.
Don't miss the opportunity. By next training, all the postgraduates see that they all join and participate in the pre-poll, post-poll, ask any number of questions, and once they complete their post-graduation, they will know what is basic ultrasound and be confident wherever they are posted. Okay.
Okay, ma'am.
MD NHM particularly was very happy to know that postgraduates from MKCG, they had requested to join, and she said we asked whether postgraduates could join or not. She said, I don't see why not. They should join.
Okay,
because we have never given education in ultrasound to our postgraduates anywhere. I don't know about outside Odisha, but in our medical colleges, postgraduate centers, we never give any formal training to our postgraduates. This is a golden opportunity which none of the postgraduates should miss.
Yes, ma'am.
Hello, Sambit. What is the percentage of poll questions till now?
Madam, as of now, 81% of the participants have attempted the poll questions.
Very good, very good. Thank you very, very much. We are happy when you are doing good to yourself. Because
Every
if you do
each and
good to
every
yourself, you'll be doing good to our patients, our mothers and babies. Ultimately. Okay, shall we end the polls now?
Yes, madam.
Yes, end the polls, and I request Professor Dr. Hashmukh sir to
Yeah,
now
I will
discuss
go
each
ahead
of the
and
questions.
right. So the first one, let me see where it is. The first question is, what are the key features that need not be included in the ultrasound assessment of placenta? And grading of placenta, as I said, is not to be included because I said that it is outdated. We were doing it in our earlier career, but because grading is just a subjective, I mean, we just see how it looks, but because there is a better method of assessing placenta by Doppler, we can assess that how the placenta is functioning. So we are really assessing the true, that is the true assessment is done by Doppler, and therefore we have given up grading these days. So we, of course, placental site, whether placenta is morbidly adherent, of course it is to be seen, but grading is not done, and 90% of trainees have answered it right.
So what is the
And
pre
sir,
and
the
post?
pre
poll
and
difference?
post difference is there is an increase in the correct response, madam, from 53% to 90%.
Good jump. Very good. Congratulations, everybody.
Thank you.
Next
the
question.
Second one is, transvaginal is superior to transabdominal in assessing the relationship of placenta to the internal os due to all of the following except. So the exception is, transvaginal, when already we can see by transabdominal that placenta is too far located from the internal os, we need not worry. But when in doubt, transvaginal is the best way to assess, and its safety is well established. Earlier, as I was also discussing this point earlier, we should have transvaginal, we should not do. But these days, even when there is a bleeding, transvaginal safety is established. It is proved that transvaginal is very safe. So 89% have done very, very right, actually.
And so the difference from pre and post is from 67% to 89%.
Good.
That's again a good jump. And it shows also that our participants are intelligent also. Next.
So number 3, in the second trimester, evaluation of placenta is done for all of the following except. And of course, second trimester, we assess the placenta in second trimester, because first trimester, there is no lower segment is not developed. So ideal choice is to do a second trimester assessment. And calcification of the placental cotyledons is the exception. I mean, we don't look for that actually, because the others are very important. The site is important, distance is very important. That 2 millimeter cutoff is very important to remember, and features of morbid adherence, because this impacts our management. And calcification, we are not worried and we don't look for that. So that is the exception, and 90% of our attendees have answered it very right.
Madam, the pre and post difference is from 47% to 90%.
Very good.
There is a big jump.
Very good. The credit goes to Pramodini madam for having clearly.
No, madam. Participants are intelligent enough.
Clear message. Yeah.
40% to 90% means credit of the presenter.
46% to 90%.
Yeah.
Good.
So number 4, the incidence of placenta previa is 5 in 100,000 deliveries. So that is the right answer. The slide, it was also there. 5 in 100 is the right answer, and 83% have attended. I mean, given the correct answer.
But the pre to post difference is from 74% to 83%.
Yes, good. But again, our participants are intelligent. They know. They're good obstetricians.
Yeah.
Next.
Number 5, sonographic indicators of placenta accreta are all except. The exception is the retroplacental myometrial thickness of 2 millimeter. That is correct, because 1 mm is the thickness where we suspect, and retroplacental myometrial thickness of 2 mm is the right answer. 61% attendees have given the right answer.
The pre and post orientation poll result difference is from 50% to 61%.
Good, good.
Again, intelligent participants.
Number 6, features of placental abruptions are all except. The exception is ultrasound cannot rule out abruption. Some 50% by 50%, we can all cases of abruption are not possible to rule out. The slide was also present. It said that 50% of the abruptions are detectable by ultrasound. So 64% of attendees have given the right answer, because abruption is also an important thing to detect, and they always end up in hospitals. And I think pain is a important. In placenta previa, it is a painless bleeding, but abruption there could be pain actually.
Then
So,
pre-poll, post-poll.
But pre and post difference, actually, madam, there is a deep, slight dip in the pre and post response, correct response, from 69% to 64%.
Why it is so?
Sir,
Because
maybe due
clearly
to
the slide, I think.
number of participants. There may be, madam, due to the difference in the number of participants attempting the poll questions.
Okay.
If
So,
less
now,
number of
of course,
participants are,
everybody is clear. Sir, please explain this again. That means there may be a placental abruption, but ultrasound may not be able to detect. That is the other side of the story.
Because smaller
only
collection,
50% can abruption be detected by by ultrasound.
smaller area of hypoechoic area may not be detected by ultrasound. That is the actually one of the key issues.
Also, to a certain extent, the echogenicity of clot can match that of the placenta, because clot will evolve. Somewhere along the line, it will be what we call isoechoic with the placenta.
Right.
And then you can't tell the difference. If you were to switch on color and you know that, yes, this area shows me no vascularity, that area shows me vascularity, then I might have it. But then for that, you have to have a very acute clinical picture. So then you'll suspect it anyway. But a lot of placenta can look exactly like the placenta. So whenever you're strongly suspecting abruption, we switch on power Doppler and we try and look at placental vascularity and try and identify clot, which will always be avascular. In fact, you might find it displacing the vascularity of the normal placenta.
Professor Khurana, can we use probe tenderness can be there in placental abruption? So
yes.
With the probe tenderness is there, but you cannot detect it. That's where you can put color, isn't it?
Yes. But sometimes you could have a focal contraction in a uterus which looks just like abruption. So tenderness is not always a good point. We will still look at the patient for tachycardia. The moment you find tachycardia and a bulky looking placenta, it is placental abruption.
Yes. Hope all of you are listening to these very important points. Next question.
Thank you, sir. Thank you for your important information.
Very, very important point.
Yeah. And number number 7 is correct method of measuring amniotic fluid index. So the transducer, as I think this was shown in the image also, and also earlier also one slide was there in earlier lecture. The transducer is placed in sagittal plane and perpendicular to the floor, 90 degree to the floor, because the returning all the echoes come back to the transducer in a 100% of the echoes are reflected back. So this is the reason why to measure AFI, that is the ideal way, and 97% of the people have given the right answer. And of course, as it has been told also, that there should not be any cord or any fetal parts within the pool actually.
The pre and post difference is from 88% to 97%.
Good one.
Good jump. So 88% are those who followed Ajit sir's talk carefully.
Right. So now regarding the amniotic fluid index, which is not true. Now normal AFI, we know that it is 5 to 24. This is true. Oligohydramnios, we have discussed the less than 5. It is also true. Polyhydramnios, it is at 24 or more than 24. And I think Pramodini madam had told already that amniotic AFI measured beyond 16 weeks. These days they are measuring beyond 16 weeks. So it is also true. So this third one, C, 19% which has been replied. I think this is the, am I right, sir? Means this at 24, because 24 here is normal. I think this is very confusing. But
no, if it is equal to 24,
yeah.
If it is equal to 24, it is wrong.
Right.
If it would have been more than 24,
yeah.
Then it would have been polyhydramnios, because up to 24 is normal AFI.
Normal.
So if it is more than 24 only, it will be polyhydramnios. If it is equal to 24, it becomes normal. So this polyhydramnios, this question actually is the right answer.
Right.
This one is the right answer.
Right. And earlier we used to learn that you measure AFI in third trimester, but these days they are saying that because uterus is there, we can imaginarily divide the uterus into 4 quadrants and measure. So in the slide it was mentioned beyond 16 weeks actually. So our earlier criteria that you measure only after third trimester. That was
but in the issue of guideline they mentioned more than 16
more than 16 weeks. Yeah. So things are changing actually, many things
so
are
I think there'll be a little confusion in the pre and post poll here.
Right.
What is it?
No, up to how? No, up to
actually,
which week we should measure DVP, and after that we will write total AFI. Is there anything like that?
Hello, Narottam, what did you say?
Madam, up to which week we will write only DVP, single vertical protect is this much, so likely is adequate. And after which week we will write the total AFI is like this. Is that anything, or always we will write AFI, full AFI index, 4 quadrant?
I think this Ashok sir had already told that when it is a polyhydramnios, it is very easy to assess all 4 quadrants, but we are not, in cases of oligohydramnios, the 2 cm cutoff is very important. So let us say there is oligo and you are finding either 2 or sometimes none at all. You know, sometimes we see that there is no liker at all, and so we mention it as virtually none. And deepest vertical pool, here is the answer. Deepest vertical pocket is better than AFI in oligo. This is more sensitive actually. So,
but sir, the maximum participants have responded to option D in both the pre and post poll questionnaire.
Here they have responded to oligoamnios. That is the right answer. Because in oligo deep vertical pool is better. It is more sensitive.
So during routine scanning after 16 weeks, we should always write AFI is this much.
Yes. ISO guideline says after 16 weeks, you will measure the amniotic fluid.
Index.
Okay. AFI. But
Hello.
Yeah.
Yes.
Hello, sir. I have a question. If the FI is 7, what should we write in the actual report? Whether it is mild oligohydramnios?
No, there is no mild.
No.
Or we should
Dr.
write
Khurana,
it is AFI 7 only.
categorically, no, don't write mild.
Write in
the
figure it is so
final.
much.
See, that's why we are so lucky to have Dr. Khurana. He is in touch with all the international guidelines, and therefore, whatever he says, we must accept.
Sir, what should we
And
write?
AFI 7, don't write mild oligohydramnios.
We write in centimeters.
Mild, moderate, severe, all those words have to go.
So we write in centimeter, AFI 7 only.
We write that amniotic fluid index is so many centimeters. In bracket, we can give what is normal, and the limits we can write in a bracket. Range, we can write the range.
Yes,
So I
sir.
think that is the ideal way.
Yes, sir. Yes, sir.
Thank you.
Thank you, sir.
Our last question for today. Last question. Which is suitable for amniotic fluid volume measurement in twin pregnancy? Yeah, in twin pregnancy, because we don't have a proper 4 quadrants in twin, we don't have that 4 quadrants in twin, because there are 2 twins. As I think there was a beautiful picture which Pramodini madam was showing, that there was a membrane on both sides. She has shown how it is measured the deep vertical pool. And I also shared my experience that when sometimes you can't get this picture, try to turn the patient. By turning the patient, the membranes are stretched. If you turn the patient toward left or right side, the membranes will be stretched, and therefore you can get this vertical pool. We have to try. It's a way of doing things. I think it is not that we put a patient in very supine position and do everything. Sometimes we have to change the position. Sometimes we have to ask the patient that go fill your bladder. Sometimes we have to say do this or go for a walk and then come back. So this is also one of the technique to be used to get an appropriate deep vertical pool. On both sides of the membrane, you can measure for both the fetuses. So DVP is the best technique, and AFI cannot be done in twin pregnancy actually. So all the questions which have been, measuring DV, I think 87% of the attendees have given it right.
And pre and post poll?
And ma'am, pre and post difference is from 75% to 87%.
87. Good. And thank you, madam,
87. So very intelligent participants. But anyway, it improved to 87% means it was worthwhile discussing. Thank you very much.
And thank you, madam, for putting all these poll questions in a very beautiful format. You have been always doing this actually.
Madam.
Yes.
Dr. Shrikanta Sahu kon pacharibaku gote chahuchanti.
नमस्कार मैडम आपण बड़े कहले आपण जे सिस्टम ऊपर हमें मापिबा मैंने कहले हो कि सिस्टम ऊपर मैंने बहुत लाइक कम थाए जो प्रेगनेंसी था एबस्ता ही आंती तने आमे सर सिस्टम ता किन लेज मार्क नेबा तापर काई मापियो नहीं मैं सुनि पहले
कौन कहले
मैडम सिस्टम पूर्व बेले प्रेगनेंसी बहुत माने लाइक कम थाए जोरा कि आवर्षण हो जाए ताले हम सिस्टम से आगु काई मापिबुनी सिस्टम से परे काई मापिबुनी हाउ दिस लैंडमार्क ऑफ सिस्टम टू मेजर एफआई
16 weeks
आगे
16 weeks रो मेजर करबानी किंतु ओटे एमती ओवरऑल असेसमेंट देखियो लाइकर ता अछि कि नहीं whether
objective
लाइकर इज
assessment हेई परबो
we don't measure it
Actually, also the fact that
Yes,
I
so
think one
yes.
of the slides which
Professor Khurana, did you understand? Did you listen to his question?
Yes. So you see, we are doing an index measurement after 16 weeks. That does not mean that we do not do an evaluation of amniotic fluid before 16 weeks. In fact, you can assess amniotic fluid as early as 7 to 8 weeks of pregnancy. At 7 to 8 weeks of pregnancy, we don't do a measurement. We see if we can fit one more fetus into the same sac. If there is enough space for one more fetus into the same sac, then I'm very happy. That is a normal amniotic sac. If it is less, I call it even as early as that as an oligoamniotic sac. Later on also at 9 weeks, 10 weeks, 11 weeks, you and me know that we're looking at pregnancies that have a poor prognosis, tend to go in for miscarriages, and yet have a subjectively less amniotic fluid. In that case, we say that there is reduced amniotic fluid, and in brackets I write assessed subjectively. It is just that we're not assessing it with an index, but we're assessing it with our eyeballing, that means just looking at it.
Thank you, sir. Thank you.
And Srikant Babu, there is also one thing you have to understand. I think this Ashok sir has earlier also told us that in the first, say up to 12 weeks, we have kidneys start functioning or they are visible beyond 12 to 13 weeks, right? And initial component of the amniotic fluid is only by osmotic process through membranes. It is not the urine. Urine volume will occur only after 13 weeks onwards. And that is why most of the amniotic fluid component is coming from fetal lungs and fetal kidneys, mostly by urine and a little bit less from the lungs. And therefore, what happens is sometimes when seen in first trimester, even when there is a complete agenesis of kidneys, still there will be some fluid. But beyond 16 weeks in bilateral, of course, because when a bladder is full, the dictum is at least one of the kidneys is functioning. And if there are both the kidneys are agenesis, then there will be oligohydramnios, and it will go up to the Potter syndrome, and which I think Pramodini madam has shared that slide nicely.
Sir, good question, sir. Sir, good question, sir.
Again, Kahantu.
Sir, हमें देखिए जे गोटे 32 weeks देखले like below 5 देखले ऐसे देखले sir. Sir, that is the only criteria to start terminal pregnancy. Now, sir.
No. Apana, you have to do Doppler. Actually, below 2 centimeter is the critical. Then you have to monitor the patient with Doppler, and those Doppler criteria, I think Ashok sir will share later on in our Doppler studies. So there is going to be a discussion as to when to deliver. You know, in case there is there are some situations when we have to premature iatrogenic. These conditions are called iatrogenic of causes of fetal growth restriction. I mean FGR. So I think he will come back to that part of lecture. In our next, we have almost 24 modules on obstetrics and 6 modules of gynecology. And maybe one more we are going to adding, because most of the obstetricians are also doing infertility. So one of our trainers have agreed. I think Rama Manjari's elder sister has agreed to give information as presentation on infertility related ultrasound. I think that is what she. So we have.
Madam, namaskar, Pramodini madam. One question. Actually, after what gestational age we can give AFI measurement in centimeter, and before which gestational age? So we should write it is adequate or borderline.
16 weeks, after 16 weeks, we should start giving, as sir told, within bracket we can write that it normal is 5 to 24. Suppose it comes around 10, 12, So FI is 10 or 12, and within bracket we can write normal FI is like that.
No, madam. After 16 weeks up to say 24 weeks, how can we take FI means 4-quadrant measurement by imaginary line or by taking
Imaginary.
pockets?
Imaginary, by imaginary, up to what extent uterus is there, you have to divide into 4 quadrants, and there you have to take.
Okay, madam.
And the transducer should be sagittal.
Yes, ma'am.
Sagittal and perpendicular to the
Floor.
Ground.
Yes.
Hello.
Yes.
Sir, Hasmukh sir, one question thila sir. Placenta, after how many weeks can you differentiate placenta like anterior, posterior, or fundal? Up to certain weeks or
Actually, right from
early
first
pregnancy?
trimester, right at first trimester, you can say whether it is fundal, whether it is anterior or posterior. The question is, in first trimester, it could be lying very close to the internal os. But then we are not going to worry about it as we can mention that it is low lying. So in our next visit, we will make sure that we look at the inferior edge better. And second trimester only, we can measure the exact distance from the internal os.
Sir, in the first trimester, how will you report? Actually, the placenta is either covering the internal os or close to the internal, touching the internal os.
You
So
can
how
write
will
the
you
distance
report?
from internal os, or whether it is covering partially, or it is completely it is covering that you can just write for our memory, because you have got so many patients. So what happens is during next visit, look at the previous report and then make
Yes,
sure
sir.
that you exclude placenta previa. That is the
Yes, sir. Yes.
ideal goal.
Yes,
No?
sir. Thank you, sir.
Ashok sir has been very inspiring. We are all getting charged up.
Yeah.
I'm so glad.
Each time we learn so much from you, sir.
Thank you.
By troubling you.
No trouble at all. It's a pleasure indeed.
Thank you so much from all of us.
Today was again a very fabulous session. Thank you so much. Yes.
Thank you so much. Ambit, shall we close it?
Pramodini madam, thank you so much. Pramodini madam,
Yes.
her
And we pray for your father
was
to get
not
well.
Her father
And
was not.
Professor Khurana, 2 of our gynecologists, their sons are in Ukraine. They're worried. One is in Jaipur, Koraput district, Dilip Biswal. His son is in Ukraine, and he's very worried. I don't think he joined this time. So we are all praying for them to return safely.
Yes. If they can send me the name and a possible cell phone number, then we can always trace them. There's no problem.
I think he's keeping in
Yes,
touch.
they should WhatsApp me the name of the child and their cell phone number, because now cell phones are working, and we will give it to the Ministry of External Affairs, and there will be no problem in tracing them and finding them.
Thank you, sir.
Yes, yes.
Dilip, if you're not there, I'll get in touch.
Ashok sir has lot of contact. Ashok sir has lot of contact there. So I think just mane tankun number ta diya jao. I think he will be able to help actually.
Yes, yes. There will be within a
Anybody
few
in
hours.
this group, if you have a relative or anybody, you please contact sir,
Yes.
Dr. Khurana, and
Yeah.
give the WhatsApp number, and he'll help us.
All the VIPs, they visit Dr. Khurana's clinic in Defense Colony. All the VIPs.
Thank you. Thank you so much for today. Today was a very, very good talk, and I congratulate Dr. Pramodi Swine for a beautiful presentation, very systematic, clean take-home messages, and I know from the post-poll that everybody benefited from that.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Okay, Sambit,
very
thank you for being there throughout, taking all the trouble for the polls. I think we'll end the meeting.
Yes. Thank you so much.
Okay. Thank you, sir.
Sambit, there are some numbers to be taken up.
आगे मैडम आपण माने पार्टिसिपेंट माने बाकी पार्टिसिपेंट माने लॉग आउट करि परंती मु से मानन को ऐड करि कि तापर मु मीटिंग एंड कर देब समस्त में आगे थैंक यू मैडम
Sambit sir. Hello.
हेलो आगे आगे
सभी सर पीपीटी रे पठेबे लास्ट वीक रे पीपीटी टा पठेई नांती
सर
व्हाट्सएप रे
सर लास्ट वीक रो पीपीटी टा मु ऑलरेडी व्हाट्सएप ग्रुप रे पोस्ट कर सारलिनी
आजी पठाइछंती आजी पठाइछंती आजी
अच्छा
पठेई दीचे
ओके सर थैंक यू सर
थैंक यू सर
हसमुख सर नमस्कार सर हसमुख सर
आज्ञा कहंतु सर
हाँ सर थैंक यू सर
धन्यवाद थैंक
ओके
Board